So I have sort of three goals for today. I want to start by sharing with you some of the modeling that was done in preparation for COVID, prior to COVID, the modeling that's been going on during COVID to help those on the front line make the tough decisions. And then I'm going to turn to CAPTRS, this new center that I have co-founded that is sort of taking a look and saying what could we have done, what should we have done, and how can we do better in preparing for future threats. So as an epidemic modeler, I feel like I've been essentially planning for COVID my entire career. My very first foray into this area of science was a project that I did with the CDC back in 2000 to help them come up with better methods for controlling the spread of silent bugs like COVID in congregate living settings like nursing homes, which is exactly one of the major challenges we faced throughout COVID. Fast forward about a decade, in the aftermath of the 2009 H1N1 pandemic, I worked for several years with the state of Texas's Department of State Health Services to glean lessons learned and to develop models that would help us prepare for and respond to future pathogens, future pandemics more effectively. So for example, if this works, I'm trying to, this is a video of an application, a desktop application that we developed back in 2011 that simulates the spread of a pandemic through Texas. The user can specify how deadly it is, how fast it spreads. They can deploy vaccines, antivirals, non-pharmaceutical interventions. And one of the most prescient features of this app is that it actually allows the viewer to watch what unfolds through the lens of a noisy surveillance system, through the kinds of imperfect data that we've been struggling to interpret throughout this pandemic. This is the exact same model, but deployed in a different version on a multi-panel display at the University of Texas's Visualization Lab. We built this version of it so that we could bring groups of public health officials in for tabletop exercises. During that same set of analyses for the state, we built online decision support tools to figure out how many ventilators should be stockpiled for different kinds of pandemics going forward, how to utilize the network of commercial pharmacy chains in order to get medical countermeasures out to all corners of the state as quickly as possible, including diagnostic tests, antivirals, et cetera, and how to manage the kind of vaccination situation we're in today. How do we get different kinds of vaccines out to different priority groups in a way that is not only effective, but is fair? Unfortunately, these were developed around 2012, 2013. The individuals in the state agency who contracted these, who really had the vision for preparing effectively for future pandemics, they left the agency. They went on because of either cutbacks or they had better opportunities. And these tools and the lessons learned were basically shelved and were not within recent memory when COVID started spreading. In 2019, we had our first opportunity to really start scaling up some of these tools to the national level through a contract with the CDC. But that work was only about maybe 70% finished when COVID started spreading. And we, along with our colleagues who are in our field and in research universities around the world, very quickly pivoted. We adapted our models, we parameterized our models based on what we were learning on a day-by-day basis for COVID. Since then, my field has been modeling around the clock to achieve three different kinds of modeling goals. We've been modeling to help the globe understand this threat. We've been modeling to help forecast the threat and also to help decision makers make good decisions, effectively use resources to contain the threat. And I'm going to provide examples of each of this type of modeling, primarily based on research that's been done at the UT COVID-19 Modeling Consortium, which is a loosely organized group of dozens of researchers from many different institutions who have banded together to provide modeling support to decision makers on many different scales. And here is a long list of the people who've contributed to some of the research I'm going to describe now. So let's start with modeling to understand the threat. This is the very first study that we did during the pandemic. And in fact, we started it within 24 hours of first hearing in the news that there was an anomalous virus infecting people in the food markets of Wuhan. So in those very first weeks, we didn't really understand what was going on. First, we heard that this was a virus that doesn't spread from person to person, then it does maybe just in households, and then it started to become clear that this thing was very contagious. But in those early weeks, we didn't know, one, how fast it was spreading, two, how many people were already infected in Wuhan, and three, how far the virus had already spread out of Wuhan and out of China. And so we tried to connect the dots. we didn't trust the data coming out of China. So in order to estimate those quantities, we triangulated based on the first 19 cases of COVID that were identified outside of Wuhan. So that was in Bangkok, Seattle, Chicago, the cities that you see here on your graph, so on the map. So we, based on the date and the location of these first 19 cases and global daily air travel data, we triangulated exactly those quantities. We estimated that by January 22nd, which is the date that China locked down Wuhan, China had only reported 425 cases. We estimated that there were probably closer to 12,400 cases. And that by the date of that lockdown, the virus was already spreading in at least 100 other cities in China. And unfortunately, in the weeks that followed, we all learned that this was, of course, true, that the virus had already started its spread around the globe and that there were far more cases than reported in China. The very second study that we did to characterize the threat was arguably the most jaw-dropping study of the entire pandemic, at least for our research group. And it was one of the simplest from a mathematical perspective. So working with a team of Chinese students, we looked for data that was published on the websites of 18 different public health departments in China. And what we looked for were case reports that provided a few pieces of information. It provided the date that the case first started feeling symptoms, but it also provided the person, the identity of the person who likely infected them and the date that that person first felt symptoms. And from that, for each one, and we found about 450 different reports that provided that information. For each one of those reports, we estimated what's called the serial interval, the time between the infector feeling symptoms and the infectee feeling symptoms. And that tells us something about the pace of transmission. And what we learned in simply making a histogram based on those 450 different data points was that this threat, this virus, was spreading much more quickly and much more stealthily than the original SARS virus, which up to this point in time, we were sort of hoping and assuming it would be similar to, because we were able to successfully contain that virus before it became a global pandemic. So what did we learn? First, we learned that this had a very short serial interval on the order of about 4 or 5 days. So it spread fast. And by comparison, the original SARS virus from 2003 has about an 8-day serial interval. We also observed this tail that sometimes it takes a while for a case to infect someone else. And so that meant that we would have to isolate and quarantine people for long periods of time to prevent transmission. But the most alarming observation were these negative serial intervals. What that meant was that the infectee actually felt symptoms before the infector. So this was our first piece of evidence that this virus was spreading silently, that this virus was spreading pre-symptomatically. And when we shared this simple graph with our colleagues at the CDC, their response was, oh no, you must have made a mistake. Go back and check your work. And we went back and checked, it stood up. And certainly within days, within weeks, there was additional data coming out that confirmed what we now don't know to be very true, that this is a silent, very elusive spreader. So I'm going to pivot now to the second aim, which is forecasting the threat. The very first request that we got to forecast what this virus would do over a longer period of time came in an email from the White House Coronavirus Task Force within days of Ambassador Birx taking the reins. And this was an email that went out to a number of different modeling groups, and it asked us to project how many people would die from COVID-19 in 2020. And our response to that request was that we can't possibly forecast that because we don't know what policies you're going to put in place, and we can't anticipate people's behavior over the next 9 months. But what we did provide were some scenario projections. And what we projected based on the models we had at the time were that if the US did very little to control the spread of the virus, then we would expect well over 1 million deaths in 2020. If we maintained strict measures that were as effective as our stay-home orders, then we could limit the deaths from the virus to under 50,000. And if we did something in between, which is essentially the roller coaster that we rode throughout 2020, we might see somewhere in between, somewhere around 400,000 deaths. In fact, the US reported 344,764 deaths in 2020. And a recent study in JAMA estimates that there were closer to 522,000 deaths due to COVID in 2020. So, one question we have to ask is, could we have done better? And I think the answer, when we look at how we've done in comparison to other countries based on deaths per capita or cumulative deaths per 1 million people, is that we absolutely could have done better. And one of the foci of CAPTRS is sort of really figuring out how could we do better and ensure that we're not in this situation again. But when you look at these numbers, you see that we sustained so far, over triple the number of deaths per capita of Canada, orders of magnitude more deaths in countries like South Korea, Australia, and China. Since then, we really have gotten to work and tried to build models that can, at least on a short term, forecast the spread of the virus, deaths, hospitalizations with some degree of certainty. There are dozens of different modeling groups that have gotten involved in forecasting, and it has really advanced the technology, the data, the efforts that we've put towards forecasting. What you see here is a screenshot from the CDC's forecasting dashboard, where they collect forecasts from dozens of groups, including ours. And then they do what's called ensemble the forecast. Those are the graphs you see on the right. And they're basically averaging the projections to get a more robust indication of where we might be going. So finally, now I'm going to turn to modeling in order to contain the threat. And I'm going to start by just mentioning, one of the potentially most effective yet most underutilized weapon in our arsenal for controlling the spread of this virus. And that is proactive testing people on a weekly basis, on a semi-weekly basis, a monthly basis, symptomatic, not symptomatic. And this is something that the UK is really just beginning to roll out. So they are now offering twice per week free testing to every single person who wants to take it as a safeguard. And the idea is if you test positive, then you'll isolate and you won't potentially be a silent spreader of the virus. So, in sort of cartoon form, imagine that this is a transmission tree. So these little circles represent people, and they're infecting people. People are infecting people as you go from left to right. And imagine what would happen if we tested this population once per week. Well, we would probably identify a bunch of these cases before they had time to infect others. That's indicated in this cartoon in the red dots. And we would prevent all those infections from happening that cascade from those red dots, as indicated in the lighter red and the lighter gray. So testing can stop transmission, chains of transmission, long before they happen. The idea to really ramp up testing on a population scale to slow spread and save lives dates back to very early in the pandemic, particularly work done by Michael Minna, Dan Larimore, and their collaborators that showed mathematically that even with using low accuracy tests, ramping up everyday testing of symptomatic people can really be life-saving. And we subsequently did a study, a cost effectiveness analysis that showed on a national scale, ramping up testing can save hundreds of thousands of lives and billions of US dollars. What I want to talk the most about in terms of containing threat is an ongoing engagement we've had in the city of Austin, where I live. And this is a picture, one of our pictures of our skylines downtown. So I live there, and I've had the privilege of serving on an executive COVID task force that includes our city mayor, our county judge, CEOs of all area hospital systems, public health authority, heads of all major universities, a K-12 school district. And this is a group that has met at least once per week since the very beginning of the pandemic, sometimes up to 4 times per week, and has collectively made the decisions that have guided Austin policy. From day one, they've asked the UT COVID-19 Modeling Consortium to provide regular types of analyses. Some of the first graphs we made were in public announcements of our stay home, work safe order back in March of 2020. We helped the city to estimate risks to the construction workforce, the grocery workforce. We helped the city to figure out how many hotels they should procure in order to have isolation facilities for our populations experiencing homelessness. But arguably, the most important analysis that we did for Austin throughout this pandemic is work we did right at the end of the initial stay home period. This was in April of 2020, when we knew the state was about to force a hard reopening. So Texas was one of those states that most enthusiastically signed on to President Trump's reopening of America. So we knew the city was going to be forced to reopen, and we wanted to design a policy that would safeguard the city and safeguard our healthcare system going forward. And so the very first thing we did in working with the city to design a policy was to ask, what goals do we want this policy to achieve? And the gut was, well, let's let's try to minimize deaths. But if you're just trying to minimize deaths, then the answer is just to shut everything down indefinitely. So that was not going to be a politically acceptable goal, a legal goal. It's something we could actually attain with the strategies that we had as our options. What we came up with as a pair of goals that met both our public health and our socioeconomic needs, as well as navigated the changing political and legal landscape, were to do what we could to prevent overwhelming hospital surges, because everybody agreed that, no matter who you were, where you were, we did not want the hospitals in Austin and in Texas to look like the hospitals in New York and Italy at the time. But if we could, we wanted to avoid restrictive measures, avoid more stay-home orders if at all possible. And so we used modeling and we used statistical analysis to basically ask two questions. What data should we track? And when should we take action in order to achieve those two goals? And the answer we came up with led to the city's policy that has been displayed in a public-facing dashboard. Here you see a screenshot since May of 2020, and it's been guiding policy now for about a year. And what you see is the policy. So the answer to what to track, that's this graph here, the y-axis on the graph. And what that is it's a 7-day rolling average of COVID-19 admissions to area hospitals. So instead of tracking cases or deaths, we found that this is the most reliable indicator of recent transmission in Austin and of imminent surges in our hospitals. And then the answer of when to act is these different color bars, is the thresholds in these Y values that separate red from orange, orange from yellow, yellow from blue. So how did we come up with those thresholds for when to take action? And let me just say that red means we're a lot of tight restrictions, orange is slightly looser, yellow is slightly looser, and so on. So how do we come up with those thresholds? Well, we developed a framework that couples stochastic optimization with data-driven simulations of COVID transmission, where we're optimizing policies under various, where the policies are toggling between different levels of restrictions. In our model, we track the 7-day moving average of COVID hospital admissions, just like we're doing in the real world. And we use optimization to solve for thresholds that give us a 99% guarantee that we will not exceed ICU capacity as long as we follow the policy, and that minimize the expected days under lockdown. So we impose a penalty for the days spent in red and orange, et cetera. So we used that method. We came up with thresholds. The city adopted those thresholds, but ever since May of 2020, we've been constantly pressure testing the policy, updating the models, updating our recommendations as we learn more about the virus and as the situation in our healthcare system changes. We have had increases in capacity, decreases in capacity. We've had near misses that led us to actually come up with a fail-safe trigger to let us know when we should set up a field hospital to handle the overflow. And most recently, now with the rollout of vaccine, we're focusing on designing a new strategy, which is really focused on how do we start to unroll some of these restrictions as the policy becomes more and more protected, and the population becomes more and more protected. So as we look back anecdotally, it seems like the policy worked as designed. We only went into one stage 5 restrictive measure during our winter surge, and it had the desired effect of curbing our local transmission so that our ICUs did not exceed capacity. That horizontal line at 200 is our estimated capacity. And you can see we just narrowly averted overwhelming it. And that's really what the policy was designed to do. From a socioeconomic perspective, when you compare Austin to other cities around Texas, we actually went into that stage 5, that most restrictive lockdown, for the shortest period of time. So we triggered restrictive measures latest and we came out of them earliest. So anecdotally, it did as we sort of expected. However, let's just take a minute and think about, were those the right goals, right? We allowed this pandemic to surge almost, to the brink of overflow, but just didn't exceed that overflow. And it turns out as we look back that those surges were not good, right? Even though we didn't overwhelm our capacity, those surges were associated with worse outcomes in the hospital. So what you see here, the gray on the bottom, that's just our total COVID hospitalizations throughout time. And what you see on the top is the probability that if somebody's admitted to the hospital for COVID, that they die in the hospital. And you can see, for example, in the 65 and older group, that's the blue group there, that there's a really pronounced increase in the in-hospital mortality rate during periods where our hospitals are fuller relative to periods where our hospitals are less full. And there could be multiple possible explanations for that. But surges are dangerous, even if they're surges that are manageable. And we also see that in-hospital mortality, that deaths from COVID hit our city disproportionately. So the map on the left shows the 43 zip codes of Austin colored according to the CDC Social Vulnerability Index. So this is sort of a composite index that captures various socioeconomic variables and is an indicator of sort of community resilience to all sorts of health threats. And brown are our most vulnerable communities, primarily in East Austin. Most of those are majority Latino. Most of our less vulnerable communities in the West are typically majority white. We're a very segregated city. And what you can see in the right map is that there's a really strong correlation between socioeconomic vulnerability and COVID burden. And you can see with some of our most vulnerable zip codes on the right, experiencing triple the in-hospital deaths as our less vulnerable zip codes on the left. Moreover, these communities, which have been hit hardest by COVID throughout the pandemic, also have been the last to get vaccinated. And so what you see in this graph is that in-hospital mortality along the x-axis, vaccine coverage to date, this is the fraction of individuals that have received at least one dose along the y-axis. Each dot represents one of those zip codes that you saw in the previous maps. And the color indicates that social vulnerability. So the more yellow dots represent our most vulnerable zip codes. And you can see that those vulnerable zip codes have sustained the most deaths and have gotten the fewest vaccines. So I imagine that in after action reports, cities like Austin and Seattle are going to be held up as decent examples of cities that tried to make good, evidence-based, data-driven, collaborative decisions that were in the public interest, both from a health perspective and a socioeconomic perspective. Maybe those after action reports will help us understand why we didn't ramp up surveillance testing or proactive testing as an effective mitigation strategy earlier or even later in the pandemic, or why we didn't do more to get vaccines out to socioeconomically vulnerable populations from the outset. But in response to a question that was posed to me and a number of other experts by a New York Times reporter about what we need to do in terms of looking back and planning for the future, I think we have to take a step further back and really think about what we need to do to overcome our collective failure of imagination even before COVID started spreading. And as I say in this quote, we spent decades planning for a pandemic that would resemble the viruses we already knew. We didn't plan for mass testing, for face masks, for stay-home orders, for politicized decision-making, or devastating racial disparities. And looking forward, we need to prepare for a much broader range of threats. And in many ways, we are starting to do that. So there are numerous efforts by government agencies, by public health agencies, by foundations, by universities to, as COVID is starting to hopefully wind down a bit, to really amass resources that we wish we had in the beginning. Better data, better forecasting, better vaccines, better drug pipelines, more stockpiles, et cetera. And so we are racing to fill those gaps that we realize we have in retrospect, but as ways to kind of be better prepared in the future. But arguably, I think we need to take a step even further back and ask what went wrong, in addition to racing to fill these obvious gaps. So what went wrong? Well, the kinds of epidemic models that we have been building before COVID-19, they predicted the emergence, spread, and containment of known threats, but not really unknown threats. Maybe variations on known threats, but not really those we hadn't seen before. And we focus pretty myopically on direct health and public health outcomes of pandemics, of pathogens. Similarly, our global preparedness strategies are largely based on the past and the present, and they don't always account for behavioral and geopolitical feedback, global state, exogenous forces. And as we saw in COVID, future threats may very well not look like the past, and their impact will be governed by complex human, pathogen, environmental, technological systems. So what's missing from our preparedness paradigm? And what do I mean by our preparedness paradigm? Well, we have agencies, we have areas of science that are focused on detecting threats, on tracking and forecasting threats once they've emerged, and responding, mitigating threats to prevent transmission, prevent death, prevent morbidity, mortality. And there are, like I said, a number of different agencies that are focused on these different steps in our paradigm. There are agencies and areas of science focused on the earliest detection of pathogens by monitoring animal populations, monitoring human populations. There are organizations focused on and groups focused on real-time forecasting, collecting better data, and this is an area that has been growing particularly fast throughout COVID. Excitingly, the new National Center for Epidemic Forecasting and Analytics and a new initiative by Rockefeller are really sort of bridging both of these aims in very innovative ways. And then, of course, there are myriad global, national, state, local agencies that are focused on mitigation. This includes military branches, public health, community organizations, et cetera. So that's our paradigm. But what's missing from this paradigm? And what's missing is the anticipation. A lot of these efforts are focused on detecting, tracking, and responding to threats we're familiar with. And what we haven't done a good job of is anticipating what other threats may come our way that don't look like threats we've seen in the past. And so how do we do that? How do we anticipate? How do we ensure that our systems, our detection systems, our surveillance systems, our forecasting systems can handle future challenges that look different than what we've seen in the past? Well, I think we have to do a few different things. First, we have to redefine. We have to broaden the concept of a pathogen threat and not just think about it as the virus and how it spreads through people and how it makes them sick and sometimes kills them. We really have to think about those cascading interdependencies in our socioeconomic and our global systems. Second, we have to imagine a much vaster universe of possible threats. We need to synthesize them. We need to chart them using human and artificial intelligence. Third, we need to use that to really understand that. We have to have basic fundamental scientific insight into what future threats might look like and what are robust strategies for addressing those threats and detecting them if and when they emerge. And finally, we have to translate that knowledge. We have to leverage wargaming and other techniques to create robust playbooks and robust players. And that brings us to CAPTRS. This is exactly what CAPTRS is. We're setting up CAPTRS to address. CAPTRS is the Center for Advanced Pathogen Threat and Response Simulation. I'm really pleased to be joined here by my two co-founders, Phil Siegel and Molly Peroni, who'd be happy to also answer any questions you have. But CAPTRS is really focused on harnessing the brightest minds, exploratory simulations, and wargaming approaches to build robust defenses against future pathogen threats. And we slot in here at the beginning. We slot in as a way to enhance what's being done in detection, tracking, and responding. We slot in here in providing scenarios, providing science, providing awareness of the kind of threats we need to be able to be prepared to detect, track, and respond to. So CAPTRS is grounded in 3 different design principles. We want to build foundational science. We want to smash the silos. We can only do this through interdisciplinary collaboration by building bridges not only between disciplines, but also between scientists, practitioners, and decision makers. And finally, we are committed to delivering science to the front lines, to making sure that those people who have to do the hard work of anticipating and responding to future threats are anticipating those threats. So CAPTRS is structured in 3 parts. We have a lab, and that's where we actually build models to synthesize the universe of pathogen threats. We have a hub where we bring in individuals from all different disciplines to help us derive fundamental insight and robust solutions via interdisciplinary complex system science. And finally, we have the arena, and that's where we bring in the decision makers to benefit from the science, to improve their plans and to be more resilient decision makers. Very briefly, in the lab, we aim to build holistic models, first of known pathogen threats. So many of our models, our epidemiological models for COVID, for other pandemics, focus pretty exclusively on public health interventions and look at outcomes like morbidity and mortality. During COVID and even prior to COVID, there have been some really cool modeling that has branched out, that has incorporated economic factors, surveillance, climate, interactions with climate, global mobility, behavior. But looking, to a much broader universe of possible threats that we need to think about there are many other dimensions, many of which are probably not even listed here, that may need to be incorporated into our planning, into our models, into our projections. Once we can build holistic models of known pathogen threats using existing data, we then have to do the work of simulating unknown pathogen threats, of varying some of these parameters and inputs and seeing how different threats might play out and how their different threats might cascade into various dimensions of our life on Earth. The hub is where we bring in interdisciplinary scholars to help us interrogate the threats. We want these scholars to help us pressure test the models, make sure the models make sense, make sure the scenarios make sense. We want them to serve as a synthetic CDC, taking our synthesized threats and deriving robust strategies for detection, preparedness, forecasting, and mitigation. And ultimately, as we work our way through the universe of threats, we want to develop a lower dimensional taxonomy of threats with key indicators spanning epidemiology, health, infrastructure, geopolitics, socioeconomics. So when we do see things happen in the real world, we know what kind of regime we're in, and we know what kinds of strategies and decision-making we should be looking towards. And finally, in the arena, this is where we will use wargaming and other techniques to help different sorts of entities, to help decision makers at all different scales in industry, in health, in policy, to develop robust playbooks and to practice making decisions in the face of intensive threat, intensive uncertainty, and perhaps really uncertain data. And so to do all of what we're talking about, to build these kinds of models, to do this kind of interrogation, and to plan for the future, we really are calling on people from all different disciplines. You know, you name a person, a professional in almost any occupation, they probably have had to do some hard work at responding to COVID on behalf of their own industry, their own hospital, their own household even. And so we have a core team, in-house experts in epidemic and socioeconomic modeling, simulation AI, and then we have all these other dimensions. And I'm sure this doesn't cover everything, but if you don't see yourself in here, please let us know. But we really, we really are looking to a wide variety of scholars, of professionals, to overcome our collective failure of imagination. So we really have just launched. We have an amazing advisory roundtable of experts in complex systems, in AI, wargaming, forecasting, industry, simulation, behavioral science, and public health. We also are starting to build a network of experts and start pressure testing our ideas and helping us move towards the beta versions of our models through things called concilia, where we're bringing together small groups of experts to talk about sort of how we're going to carry this out and hopefully get them involved in all the activities that I just described to you. And we have some core values. So CAPTRS wants to have an enduring impact. We want to break down barriers across disciplines and between science and decision making. We're hoping to recruit an unmatched team of internal and external collaborators, and we strive to be apolitical in everything we do. So with that, we would love to answer any questions you have, welcome your suggestions, and feel free also to reach out to us directly or at either of the emails that you see on your screen.
Thank you, Dr. Meyers. That was amazing, fascinating, and quite a lot to take in. We do already have a few questions. Neil Jablon, would you like to ask yours directly? Unmic yourself.
Sure.
Yeah, thanks.
Sure. My question, obviously, China is a key part of this exercise. So my question is, where does China fit into this whole exercise, and how does CAPTRS work with China?
So CAPTRS is not directly working with anyone in China at this point. I will say that my modeling consortium has a lot of collaborators in China, and we are really sort of at the initial stages of building the network of collaborators that we hope to include going forward. And so I think that I absolutely take your point that ultimately this is going to be a global effort, and we need to be learning lessons from China, but certainly also collaborating with them and ensuring the globe is prepared going forward. And so that is certainly something on our radar, but we're not there yet.
Okay, thank you.
Sarah Hooper, would you like to ask your question?
Sure. Thank you so much for the talk. It was great, very interesting, and obviously important work. I'm curious if you're concerned or thinking about kind of in the next few years, if there might be waning interest and support for this kind of research. You mentioned in the early 2000s after the previous SARS outbreak, some of the papers were kind of put on the shelf and there was reduced support. I'm worried, or I'm curious if you're worried about that happening again, or how to prevent that from happening again as we forget kind of what happened in 2020.
I'm extremely worried about that, I have to say. I mean, that has been my experience in my entire professional life, is that there's a lot of really good work done in the middle of crises, in the immediate aftermath of crises, and then it's shelved, it's forgotten. What we saw between 2009 and 2019 or 2020 was that we have a very sort of impoverished public health system, and there was downsizing, there was pivoting resources from pandemics to Ebola to Zika, and no sort of institutional memory. And so I think, under the status quo, I think we're at great danger for not being prepared for future threats. That said, right now we're seeing just intensive energy and resources because this had an unprecedented impact on the globe, on the United States. And so I think it will not fade from memory quite as quickly as some of those other threats. But I think, the hope is that while it's still a high priority, that the investment that governments are making now and foundations are making now will be sustainable investment, so that organizations like CAPTRS will be around and will be continually preparing. CAPTRS work is really before the next threat, right? CAPTRS work is really helping us to envision the kinds of threats we might face in the future, and now put in place the decision paradigms, the data collection systems, the playbooks, training decision makers today, so that if and when a threat emerges, we'll be much better prepared.
Great, thank you so much.
Rob Barrett, would you like to ask your question?
Thank you. So within this CAPTRS model, what do you have in mind for how to involve this wide range of experts in all the different fields that are relevant to the work when they have existing full-time jobs, but might be very interested in contributing to the kind of work that you're doing?
Yeah, I certainly appreciate that. So we are working on the model, but the idea is that we would provide a mix of grants that actually provide you with support to do research in your own lab that is synergistic with what we're doing. We also provide funding so that you can actually sort of buy out some of your time, or maybe spend a month in the summer with us, so that you can set aside your other duties and really immerse yourself. And ideally we will bring in groups of scholars, at the same time. So it really, we're doing collaborative work. And so I'm very, somebody who has been in academia my entire career. I'm very well aware of just how hard it is to carve out time to think big and collaborate. And we're trying to come up with ways to really incentivize scholars to do that and make it easy for them.
Great, thank you.
Robbie, do you want to ask your question?
Lauren, thank you so much for sharing such an exciting vision for CAPTRS, and congratulations for getting so much work done so quickly and showing the kind of impact that you had on the Austin community. It's really inspiring. You have an incredibly exciting and comprehensive vision about collaborators, and you just spoke to Rob, particularly in regard to external collaborators and how you might bring them in, either on site or sponsor research that they might do in common areas to CAPTRS. But I'm wondering if you can speak to your plan, your hiring plan, for example, over the next 12 to 24 months. And have you been able to sketch out the types of positions and skill sets that you might be looking for to actually bring on board at UT?
Yeah. So I just want to clarify one thing, that although I am at UT, And CAPTRS has a close partnership with UT. CAPTRS does not actually sit at UT. It's a separate center. And we have a number of partners, including UT and the Santa Fe Institute, and IBM and Boston Consulting Group. So we have a number of partners. So I think it's a great question. And I think that it's a work in progress, but we absolutely are going to be looking to hire a core team of modelers. We want people who have expertise in simulation, in artificial intelligence, in modeling epidemic dynamics and modeling socioeconomic dynamics. So the core team, the very technical core team, we're looking sort of in all those dimensions.
Thank you. Alexander Siegenfeld, would you like to ask your question?
Yes, thank you. Thank you so much for your presentation. I was wondering why you think the US and much of the world aimed for mitigation rather than elimination, given that elimination would both minimize the death and also minimize economic costs if one looks over, even like a year, as we saw in like countries in China and Australia.
It's the $1 trillion question, but I mean, this is just me speaking, and I think this is the kind of work that, first of all, CAPTRS is aimed at, and hopefully will kind of guide us towards making better decisions in the future. But I think, in retrospect, one can do these sort of counterfactuals and say, what if we had mitigated for elimination? And you can do those estimates and show it would have been life-saving and cost-saving and all those things. But I think at the time that those decisions were being made, even if people were modeling that, there wasn't enough time for those models, those results to really be translated into an intuitive way for the people who were making the decisions. And and everything was so politicized throughout, even today, but certainly in the beginning. So I think, it's this sort of failure of imagination, right? If we had thought about COVID before and we had simulated it and we had the models, and in the models, we had realized what the socioeconomic impacts would be of these stay-home orders, and we had seen, I mean, what our modeling in Austin really clarified for the city was that if you act early and you act hard, you can stop outbreaks in their tracks, and you also have benefits on the back end, because if by stopping things earlier, you just don't have to hold on to these restrictive measures for as long in order to get the virus close to elimination. And so if we had that kind of insight earlier, right, then maybe, and let me just add, and if we had, if public health in the United States really had authority, right, then maybe we would have made more data-driven decisions that would have been better sort of from a, human and economic perspective. But, I don't know, that's sort of my guess. I do think there's going to be a ton of sort of after action analysis and finger wagging and stuff like that. But that's going to, I think, getting to the sort of the motivation for CAPTRS, I think a lot of that retrospective analysis is going to tell us what we should have done for COVID, and what it's not necessarily going to tell us what we should do for the next threat. And I think that's, that's what's going to be really important going forward.
I'm wondering, Phil and Molly, if you would like to add anything at this point and maybe talk about the timing as things are moving forward.
Sure, I'll add a couple of things to those questions. Just one other point that I'd like to make that is really important, which is we were very careful in the P in CAPTRS being pathogen, not pandemic, because our basic idea here is not just to prepare for pandemics. It's to provide a way of preparation for even a local outbreak. The example I like to give is, I've lived for many years in Chicago and love Chicago, and it's very dependent on Lake Michigan for both its economy and, for a lot of other things in the city. How would Chicago prepare for some kind of pathogen threat to its water system? And that's not something necessarily that you have to model on a global scale, but it is something that if I were a citizen of Chicago or in the public health system in Chicago, I would love to see the modeling behind how you prepare for something like that. So our goal is not just to provide pandemic preparedness. It's kind of a broader applied research to help people in all scales. The second thing that I'd say that I think is very exciting is asking the question, why did we do so poorly? I kind of liken it. I like to use analogies. I liken it to whether you like how our politicians or our public health officials behaved or didn't behave, whatever. Imagine that they all were asked to get into a race car and immediately, for the first time, and try to go around a NASCAR lap at 200 miles an hour. Imagine yourself trying to do that, and you've never been in a race car. You've never been in a car that goes over 100 miles an hour. It would be a very difficult task to ask somebody to do that. In South Korea, in a lot of parts of Asia, and even in parts of Africa that did a lot better than us, they've been in those race cars before. They have prepared much more than we did. And so our goal is we're going to do the work behind, helping people understand how race cars work. And then we're going to put them in race cars so that when they have these threats, we're going to put them in simulated race cars, I should say, so that when they have these threats, and they're asked to get into a real race car, at least they have a shot at doing a much better job and, getting around that lap. So those would be the two things that I'd add based on some of the questions.
Thank you. Molly, would you like to add anything?
Thanks, Carla. I just want to say thank you for including us. Just the Hertz team has been exceptional to work with. And as you can see from what we talked about, there's been quite a lot of collaboration occurring already. And we're relying on that and super grateful. I can see several people on this particular Zoom that, and thank you to you all as well. It's been great to work with you. So thank you.
We do have a couple of other questions. Jessica?
Well, I was just wondering, recently it's been on the news, for example, the huge surge in India and the problem for them in coming up with raw materials to develop their vaccines. And there are other areas of the world too, many of which have governments that may be not very forthcoming with the actual numbers of infection in the country. And how do you include that in your modeling? And then I also see that the next question here says moral hazards of such modeling, but whether or not we contain COVID over here, if we have these enormous hot spots elsewhere, it's just a question of time before the pathogen enters the US again, right? So it needs to be a global response, right? Do you think the US is doing enough, or?
So I guess, do I think the US is doing enough, and what should we do in COVID? I mean, absolutely, we need to be considering COVID on a global stage. We absolutely, as we think about what does COVID look like long-term in the United States, are we going to be kind of combating it for months, for years ahead? Is it going to be one of these, viruses where we're boosting every year? All of that absolutely depends on global dynamics, global efforts to get out vaccines, the molecular evolution of the virus in different pockets, et cetera. So 100% our modeling and our planning have to think globally for COVID. And then with respect to the models that CAPTRS will build, or the scenarios that CAPTRS will synthesize, absolutely, that will also have to be sort of in a global context. And we'll be thinking about threats, although Phil mentioned Chicago, we will, also be thinking about threats that emerge on the other side of the globe, and thinking about how does the global airline transportation network impact if, when, where it will first arise? What does it mean as far as alignment between different governments in terms of data sharing and policy making? And so all of that, ultimately we imagine will be part of the scenarios and part of the simulations that we build at CAPTRS. And you mentioned this other question about moral hazards from such modeling, and I'd love to understand more what that question means and get a little more perspective on that.
Well, I guess that comes to me. I know it says Deborah Roberts. That's my wife's name, Zoom account. I'm Mike. I come from, you might say, a national defense background. Worked at Livermore for a while. And my first concern is that your wargaming will be wargamed. That countries like China will develop models like this and will use it to explore our vulnerabilities. And that we need to be aware of that and planning for it. I'm glad that the naval warfare people are involved in this. I'm also concerned in the moral hazards of government intrusion in freedom in America. And I know that's a political thing and you're trying to avoid politics. But when I signed on as a Hertz fellow, I signed the bottom line that, we're doing this for America. Getting a Hertz Foundation fellowship means you need to say you are willing to help the country. And our country is distinguished from all others by a constellation of rights. And I am very concerned about governments being, as I describe to people, it's like trying to play with the food of a moray eel. If you give government the ability to lock it down and that sort of thing. I'm very pleased that you guys are trying to minimize that to the extent possible. But those are the two moral hazards I see.
Yeah, thank you for raising that. Those are really interesting. And, or at least when I've been thinking about the analogy to wargaming with what CAPTRS is going to plan to do, really the enemy was the virus or the pathogen and all of the sort of cascading impacts in other dimensions. And so it was a non-human opponent, but I take your suggestion to heart, and that, I think when we think about what other dimensions need to be considered in these scenarios and need to be modeled, I think things like, civil rights and government intrusion, and also are other countries going to play by the same games? And hopefully what comes out of that is that, if we learn from the scenarios and from this kind of science that, a disagreement between two countries can completely undermine great efforts in a country, then that will be a priority for planning, right? Is how do you build those global health bridges so that in times of emergency, there are international arrangements that will sort of, at least to some extent, help ensure that those kinds of human to human conflicts don't undermine our ability to respond.
If I would just put in a short post note is, for some of us who have not been involved in the sciences, you folks have so deeply been, and I'm very thankful for it. It appears that much of the success of getting a vaccine was getting government out of the way. And I think that businesses and America's strength as a logistics power really came to the fore in getting the vaccine and getting the vaccine out to the rest of America, and really emphasizing what the business community can do independently if they get this kind of information to try to figure their own ways to isolate small populations, because that's kind of what the crux of our issue was, is how do we isolate just the people that need to be isolated and not others. And I think that the business community, if brought in, could have lots of ideas. I like to say no one's as smart as a billion people. The market needs to be able to address this.
Well, if we don't have any other questions, it looks like we do not. I want to provide a hearty thank you, Dr. Meyers, for your presentation, for Phil and Molly for bringing this to us, for everyone who joined us today. I've been posting in the chat that we do have a survey that we'll be sending out today and tomorrow. We'd love to get your feedback. if you do have any other questions, the two emails that have been created for you are hertz@captors.org and info@captors.org. You can get more information, ask more questions there. And with that, I just want to wish everyone a wonderful rest of your day, and I look forward to seeing you again.
Great. Thank you so much
Thank
for
you.
having us.
Thank you.
Yeah.
Thank you.
Bye-bye.
Aloha.